Okay, hello. So I would love to suggest if we could go over what we've learned thus far. Probably, presenter, you could ask a few questions while as we wait than being mute because we don't know how long this will take.
Hello. I also want to ask, this slide, I think should be made available to us at the end of this workshop.
I think it's a good thing we can have a bit of discussion while we are waiting. At least we are not doing and we are not continuing with the session like with the presentation, but just a bit of discussion. Maybe you can unmute, or maybe in the chat, just let's hear some people. What role are you in? How is the role like? Something like that. Just a bit of keeping the house lively. Hello?
Hello, good evening, everyone.
Yeah, good evening.
My name is Fumi Adeniro, and a physiotherapist practicing in private practice. And as you were lecturing us, I just remembered a case that I had seen, I think about 6 to 7 years ago.
Yes.
It was a case of a woman with, I was called in to manage her for low back pain. But on examination, the interesting thing is I didn't notice, she didn't have foot drop. What she had was like reduced knee extension, like the power of the quadriceps was, I think, about 3. So I noted that and I thought, okay, well, in a case of sciatica, that could be happening. And then we started management. And I noticed that when I saw her by the next visit, I noticed that the muscle tone of the quads started to reduce. So, and I now checked and discovered that even the power of the quadriceps was also reducing. So at that time, for me, I felt it was a red flag, and I alerted the family and told them that they might have to see an orthopedic surgeon, let them check, because there might be something else going on. This was like 6, 7 years ago. What I noticed is by the time the family was, trying to arrange a visit with the doctor, it took another 2 weeks. By then, the lady had zero power in the quads, but she still had foot. She was still able to do dorsiflexion and plantarflexion, but it was only the quads that was affected. Eventually, they had to go and see the orthopedic surgeon, and they recommended a surgery, and I lost contact. When I checked back with them, because they wanted to do the surgery, I think outside of Lagos. Unfortunately, the patient didn't make it, but I just remembered her as we were discussing and realizing that I think there are other things we also need to look out for aside foot drop. If the muscle tone, I don't know, I guess I'm not the lecturer here today, but I guess if you're noticing that there's a reduction, a reduction in muscle tone or atrophy happening within, even if it's one particular foot, because for her, every other thing was fine. It was just the knee extensors, which is the quadriceps. I believe that the lesion might have been higher up, maybe L1, L2, L3.
Was she having back pain?
She was having back pain. Yeah.
Was
so
it
we're managing
severe?
her.
How severe was it?
It wasn't severe. It was very mild.
Can you remember if she have any other comorbidities? What is her age?
Can I remember her age? I think she was about 70, so 71 thereabouts. Was an elderly.
Any comorbidity?
None. She didn't have diabetes. She had high BP, yes, but not diabetes. And she didn't have any paresthesia sensation. She didn't even she didn't even notice that there was anything. She just, the only issue was that she couldn't walk properly. So it was in the course of my assessment that I discovered that all the other muscles were maybe about 4, but the quads just kept reducing in power until she could no longer extend her knee.
So in
At
this
that time,
condition,
okay.
in my own, sorry, so I think in my own view, when you look at it, it's only the quads that we have an issue with. That will be somewhere around L2, L3, L4.
L3, L4,
Yes.
yes.
So, and that's the only thing that she was presenting with.
Yes, that was the
Was
only
it
thing.
bilateral?
Yes, that's
No, it was unilateral, the left leg.
the right was
Left
fine.
leg.
No family history
The
of
right was
cancer,
fine.
and she did not have like any history of infections. It can be anywhere else.
Well, that was well back. I'm not sure I
Yes.
checked for infection or anything. At that time, my mind was just, oh, this is back pain. And something is going on with the vertebral, maybe the
Definitely.
disc at that
Yeah, at
point.
that level,
So my
yeah.
mind was just, this is an orthopedic case, let me refer.
Yeah, yeah,
And I'm glad I did, because they eventually scheduled her for surgery.
yeah.
But because he had done the surgery outside of Lagos, I couldn't follow up with the case.
And you didn't know what sort of surgery was done then. Was it a
I
decompression?
don't know.
Did find out that
I'm not.
there's a collapse in the L4, L5 region, or like
Okay.
a compression, or what was their reason? Like on what basis did they do the surgery? Like
The
what were they
surgery.
trying to
Yeah,
achieve with the surgery?
I actually was interested in knowing, but
Yeah.
because the family had moved her out of Lagos, I think they had the surgery somewhere in Abuja. They weren't communicating as much as I would have loved them to.
Yeah.
So I wasn't able. I just remembered the case because I realized that it was a good thing that I referred her. Eventually, she went for surgery, and she might have had physio over there.
Yeah.
So I did eventually find out what sort of surgery it was. But I remember thinking that, so now when I'm assessing a patient, I begin to see reduction in muscle tone, reduction in muscle bulk, and reduction in power over a period of a short period, like 2 weeks, then that's a red flag.
Yeah.
And it's just better to refer.
So
Unfortunately, I can't tell you more about the
yeah, we
patient.
don't have much to as regard this patient to think if it's due to motor neuron, anything that has to do with such we've got like less information as regard this patient to be able to conclude on something. But yes, I think one thing that you did reflected on, like hearing what we've just started to discuss, is timely referral, which is a very good thing. Like for some physios, they might think, no, this is something that we can manage, there is something like we can just do some strengthening and it will get better. And with the back pain, we can just optimize using some, modalities, and that will also, I'm glad you did the referral. So that's the most important thing. Mostly, I think what we need to always remember, or what we've got to always remember, is managing a patient shouldn't be like our sole responsibility. Usually, it's multidisciplinary. We might think maybe, let's say the patient might come in with foot drop. I don't want to say it before I get to that point, but we might think as physios, we've got a lot we can do. But if she's having other symptoms, like other associated factors, we might want to involve other multidisciplinary team to optimize the outcome of the patient. Do you get? So it's a good thing. It's a good thing you reflected on it. And moving forward, I know you will always be more than happy to escalate if there is red flag. Hopefully, you will get to know more by the end of the session, hopefully. Any other person?
Yes, thank you.
Yes, Shaba, just to let you know that people have joined the Zoom, the YouTube link, just to let you know.
Okay, so we can continue, sir.
Yes, I think so, unless if you want to take more questions, but it's up to you.
All right, so we were just trying to just keep the house lively. So I'm okay to continue. So sorry. So when we talk about the causes, I think we're done with the causes. So yeah, these are the common causes of the foot drop. We're at the causes, central neurological causes in the case of stroke, multiple sclerosis, and ALS. And sometimes it can be caused by muscular dystrophy. Muscular dystrophy, as in the case of myotonic dystrophy, which is usually seen in middle-aged individual, can present also with bilateral foot drop, no, with or without pain, mostly without pain. Then we can also put at the back of our mind as a differential. It could be of muscular dystrophy origin, especially if there is no back pain, or the inflammatory myopathies also. So, as I said, acute foot drop is a neurological deficit, and it should prompt for urgent assessment to determine the cause and if there is need to do urgent review, then yeah, we need to always put that as at the back of our mind. Let's see. Sorry. It's happening. Yeah. Management of the foot drop. So we've now seen the foot drop. We've seen several causes, like different causes of the foot drop. When we've got a patient presenting with foot drop, how do we manage it in the primary care? Well, there are basically like 3 ways of managing foot drop, but more specifically 2 ways. So the first one is the surgical intervention. But then for surgical intervention, there are some indicators that we look into for us to say, okay, maybe we should opt in for like surgical intervention for the patient. And the two most important indicators are the onset of the symptom and the pain. So let's say a patient presenting with acute foot drop within 2 to 4 weeks, mostly 2 to 3 weeks, but it can be extended to 4 weeks, and then with severe pain, pain in the lower back and pain in the foot, then that is an indication, that might be an indication for surgical intervention, because there are other factors that we also need to look into. So with acute foot drop and severe pain, then we might look into it. Pain in the foot, but when we talk about when we see a patient coming in presenting in the primary care or in our clinic with foot drop more than 6 months, but with no pain, there might be pain. Pain might not be severe. Sometimes the pain will be there, but it's not as severe. So depending on how the patient perceives their own pain, how the pain is for the patient, that's also what will determine for surgical intervention. Then we also consider the age of the patient. When we talk about age, according to studies, it says 60. Any patient that is above the age of 60, so the benefit of surgery will be less compared to, like, when we compare the benefit and it will out, how will I say it? The benefits and what should I use?
The risk, the risk.
The risk, yes, sorry. Thank you. That's it. The benefit and the risks. So we have to also look into that. For AIDS, when we look at it, it's not the age per se, it's more with comorbidity. So let's say we see an individual sudden onset of pain, sudden onset of foot drop with severe pain, but the individual is 30 but have got other comorbidity. Then if we opt in for surgical intervention, the risk will outweigh the benefit, because if he's got like uncontrolled diabetes, previous history of blood clots, definitely we're not going to be thinking more surgical intervention for this sort of patient. But if you've got someone who is in the 60s, past 60, with no comorbidity, severe pain, acute onset, then that can be like we can opt in for surgical intervention. Another thing is the muscle power. So when we talk about the muscle power, according to the Oxford grading, let's say again the research says 3. There is a kind of debate. Some say 3. That's when it is considered as a foot drop. But when you look at it with 3, it's gravity, and the patient can still go against gravity. But then they argued that once the patient get moving, then that 3 can drop to 2. Again, so that's why they classified that 2, a muscle grading of 2 out of 5 is considered as foot drop. So with surgery, we are expecting to gain 1 more in the power. So if we've got an individual with a muscle power of 3 and then acute pain, acute foot drop and severe pain with no comorbidity, thinking we are going to go for surgical intervention, I think the benefit surely will outweigh the risk. So we can try. But in the situation that we've got a patient with 0 power, and then we're going for we're thinking surgical intervention, we're going to get, let's say, 1. With 1, are we still going to get what we want as per functional wise? I don't think so. So here we also look into that benefit and the risk. And the last one is the patient preferences. Sometimes patient might say, okay, yes, we are okay with the surgical intervention. Sometimes patient will say no. No matter what, we've got to always look into the patient preference. And the next management is with the conservative, the next form of management is conservative management. Obvious, in researches, most of it are retrospective studies. It's shown that both the conservative and the surgical intervention have got the same outcome, like what we get when we do the surgical intervention. That's the same outcome for the conservative management. Of course, when we are thinking towards conservative management, or when we're planning on conservative management, we don't just base our plan on our clinical findings. We've got to image it and see what is really causing the foot drop from our own like from the imaging view. Let's see if there is any compression in the disc, or if there are any other form of causes which can be screened with the imaging. Like it can be MS, it can be anything, it can be anything. So the best thing to do when we are considering also conservative management is to first image it, and of course optimize pain management during the neuropathic and the NSAID. Here in the UK, the neuropathic it's also, according to NICE guideline, it's not too much advice, but because of some patient with some patient we cannot really do without giving them, and so we can use them. So another input from the physiotherapy, and then from the orthotic input also from orthotics. The last one is the injection. Of course, this is another intervention, but mostly not recommended. Injection, we cannot go for injection without imaging. Injection usually is now block, and also input from orthotics for support to prevent fall while undergoing rehab program. So yeah, that's it. And we move to the next one, which is metastatic spinal cord compression. So metastatic spinal cord compression is not that common, but then when it presents, if not identified, it can lead to significant consequence. This include depending on at what level it happens. It can happen at the lumbar region, it can happen at the cervical region or the thoracic region. So when it happens when there is compression and the lumbar region, then it's known as the Cauda. It causes Cauda equina syndrome. And when it happened at the upper part, that's the cervical or the thoracic, then it's caused compression to the spinal cord. And it's most common in the thoracic region. So it's a serious condition that occurs when cancer spread to the spine, leading to compression of the spinal cord or the Cauda equina, depending on where it's happened. And early identification is also essential to prevent risk. What are the common primary causes, like common primary cancers that can metastasize? to the spine. We've got the three big ones, which is the lung cancer, the breast cancer, and the prostate cancer. The lung cancer constituting about 20 to 30%, and the breast cancer 20 to 30 as well, prostate 10 to 20, lymphoma 5 to 10%, renal cell carcinoma is also 5 to 10%, and multiple myeloma, usually the undiagnosed multiple myeloma. Those are the ones that can get metastasized and cause significant consequences. So the key concern in primary care, so persistent severe pain, spinal pain, especially in patients with a history of cancer, we should think metastasis, and this require urgent escalation. So we look at some clinical presentation for metastatic spinal cord compression. The first thing we looking out for is acute pain, sudden onset of pain, localized to the spinal region. Pain is worst at night or when lying down, and it can radiate to the limbs depending. Some they don't have radicular pain, some they do have. And because there is a compression, then we're definitely expecting neurological symptom. Neurological symptom has to do with like motor and the sensory function. So limb weakness, numbness, tingling sensation, sensory changes around the torso, especially if it's happened in the cervical and the thoracic region, then we are expecting sensory changes around the torso. And we've also got autonomic dysfunction that has to do with urinary retention or urinary incontinence. So when we talking about urinary retention, then we're talking when the compression is in the lumbar region. And when we're talking about incontinence, then when it is high up. And then we're also talking about bowel dysfunction. We're also looking for bowel dysfunction. Reflexes changes, we've got hyperreflexia below the lesion and positive Babinski sign. And we're also expecting a kind of gait disturbance, difficulty with walking, balance problem, coordination when the individual is walking. And sometimes they might also present with a kind of frequent falls. So it's of clinical concern when we see, it should be of clinical concern when we see a patient presenting with spinal pain. If the patient have got a previous history of cancer or even a family history of cancer, it's something that we should really look into. And if there is neurological presentation. So if there is a neurological presentation, severe pain with neurological presentation, then it's a spinal team assessment, spinal team referral. But if it's pain with no neurological symptom in a patient with previous history of cancer or family history of cancer, then it should prompt an urgent medical review or oncology review. Now we move to another big one, which is the spinal infection. Spinal infection is an infection that involves the spine, like any infection that involves the spinal structures, most commonly in the IV disc. It can happen, and sometimes the vertebral bone itself causing osteomyelitis or an epidural abscess around the spinal cord. All this can cause a kind of compression to the spinal cord or the spinal nerve itself, and then causing major complication, which if it's not recognized, definitely will lead to significant consequences. Again, spinal infection are very much hard to identify because we cannot really see that classical sign of infection as in other peripheral joints, where you see the swelling, the redness, the hotness, and like all those visual, like obvious signs of infection. But with the spinal, because it's quite deep, so patient usually present systemically ill. That's another one sign that, yeah, something is going on. Spinal infection can occur due to hematogenous spread. It can be from another side of the infection via the blood. So if you're thinking, if a patient presenting with pain in the spinal region, but have got infection previously, that should ring a bell. We should always check that. We should always note that we should always keep that at the back of our mind. It can get spread to the spinal region When there is contagious spread from nearby tissue, it might be from a nearby tissue, can also get into the spinal area. It can be from direct inoculation after maybe a spinal surgery or injection or trauma even, or fracture. With infection, there are some factors that predispose, that we see, that we also think this patient might be predisposed to spinal infection. Immunocompromised patients, patients that have got IV drug use and recent infection elsewhere in the body, and also with diabetes mellitus. Some of the findings that we have to go, like examination findings, that mark pain with movement. So if you've got a patient that got pain with movement, severe pain, then that should also ring like, yeah, we should have it at the back. It could be a spinal infection. We should screen for infection. Spinal tenderness, muscle spasm, and gross restriction of spinal movement, and neurological, of course, because if there is a compression, then definitely, if there is a compression in the spinal cord, then there will be neurological deficit. And if we see such, then we also have to really screen for spinal infection. Always suspect spinal infection in patients with severe, constant, non-mechanical back pain who are systematically unwell or has infection risk factors and escalate urgently. Sometimes we see patients coming with back pain. We don't really screen for the spinal infection, and we think, oh yeah, it's just mechanical. It will go. It's physio. We can handle with physio. It's good to check for the red flag. Check for red flag for all the significant spinal pathologies. We've got to check for their red flags. Make sure we don't have it. Then we can conclude. And then we move to the big one, which is the Cauda equina syndrome. And so the Cauda equina, as we all know, consists of approximately 20 nerve roots arising from the conus medullaris and supplying the lower limb, the bladder, the bowel, and the perineal region. So when there is a compression to the nerve roots, that is when we've got Cauda equina syndrome. It can be caused by a good number of things, including large prolapse lumbar disc, lumbar spinal stenosis, either narrow or spinal canal, spinal tumor or metastatic diseases can also cause it, spinal infection, trauma or vertebral fracture can also cause Cauda equina, compression to the Cauda equina, and then hemorrhage or hematoma. What are the symptoms that should arise suspicion when we've got patient presenting with back pain? It can either be unilateral or bilateral, with unilateral or bilateral leg pain. So back pain, unilateral or bilateral leg pain, we should think Cauda equina. Perineal sensory changes. So when we talk about perineal sensory changes, any like numbness from the front passage or the back passage, we should also think Cauda equina. Then we talk about altered, altered bladder sensation. So when we're talking about altered bladder sensation, a lot of people confuse incontinence with it's not about like incontinence, it's about the difficulty to initiate micturition, because if you look at it, the S2, S4 sacral parasympathetic nerve supply to the bladder is responsible for initiating micturition. So when we've got up compression at the Cauda equina region, then we're expecting more of retention than complete incontinence, because it's patient might be like, I'm not able to initiate micturition or fully void when I go to the loo. So we should also think Cauda equina. And when we, another thing is to also look out for is sexual dysfunction. So with sexual dysfunction, it differs in the gender. So with the male, we're expecting like difficulty to get erection, difficulty to maintain it, and difficulty to ejaculate. With the females, quite tricky. It can be difficulty to reach orgasm or like abnormal sensation. So all this we need to just rule it out before we can conclude if it's a mechanical back pain or if it's a serious spinal pathology. So, like I said, urinary symptoms that matters: neurogenic urinary difficulty, loss of desire to void, straining to empty the bladder, reduced urinary sensation. These are the urinary symptoms that we need to ask the patient. It's a medical emergency that requires urgent investigation and referral. That's a CES. And CES classification and diagnostic accuracy. So let's quickly look into see how we classify the CES. So we classify in the first classification is the suspected CES. So when we suspecting CES, patient is coming in, back pain, unilateral or bilateral leg pain, then we're suspecting it could be. Let's check further. Is there any change in your with perineal region? Is there any saddle anesthesia? Like if you finish using the toilet, you wipe. Is there any numbness around the genital area? Yes or no? Then that will also make us to think: are we suspecting like Cauda equina? Then altered bladder function, like I said, you have patient come in, ask if they are having difficulty to void, difficulty to initiate the micturition. Then we also thinking, suspecting it could be Cauda equina. Then we'll talk about sexual dysfunction, depending on the gender. Ask. Sometimes we kind of feel shy to ask, but to be honest, we just have to ask in cases where there is medical legal issue. If it eventually turns out that patient is having Cauda equina and you did the screening, you like screen for every other thing, but you didn't ask for if it's in a place where they like pay for for all those stuffs, they will definitely sue for just one thing that you miss out for. So it's very important that we screen out for everything. And the next classification is for incomplete Cauda equina syndrome. Still, we've got urinary difficulty of neurogenic causes, loss of desire to void, straining to empty the bladder, reduced urinary retention. So here, it's I kind of move from this stage to the other stage. More has to do with the bladder function. Then we get to the CES with retention, painless urinary retention, and then we have the overflow incontinence. At this point, there is a significant compression, so patient is not able to fully void, so there will be incontinence, there will be overflow. And then there's the complete classic like CES, which is the complete loss of function of the Cauda equina, leading to paralyzed bladder and bowel. At this stage, it's affecting more the bowel, and then it affects also more the bowel, sorry, and then there is absence of perineal sensation. So with this, I think the complete when we talk about management, the complete CES, usually surgical intervention not indicated, but because if you look at it, the risk outweigh the benefit already, the damage has already been done. We are not expecting all those neurological deficit to come back. Like we cannot reverse those neurologic damage. And then if we opt in for surgery, then definitely its infection can come in, high risk of infection and stuff like that. So not indicated. Pain optimization in case if there is pain, then that's the best management for that patient. And in the case of CES retention, when we've got patient with CES retention, of course, we might have done like the urgent referral. That will not be at the primary care. That will be more in the secondary care. So usually they try as much as they can to make sure that they operate CES incomplete and CES retention as soon as possible, just to prevent significant damage. So that's why at the primary care, we look into the suspected cases like, yes, we are suspecting, same day emergency, same day imaging. So definitely have to image, referral to the spinal team, imaging, and then they just take it from there to decide what management, what is best for the patient. Well, let's look at the diagnostic accuracy. We're looking into, excuse me, sorry. Sorry. So we're looking into specificity and the sensitivity of all the signs and symptoms. So when we look at the specificity, so the specificity is for ruling in that someone have got, like we're suspecting spinal CES. So with sensitivity, it's ruling, like for specificity is ruling in, and sensitivity is confirming that yes, most likely someone has got spinal Cauda equina syndrome. So we look at the saddle anesthesia. We look saddle anesthesia, that is changes with the perineal region, like with the front passage and the back passage, has got the high and the specificity of 0.85 and sensitivity of 0.8. So when we're looking at bowel incontinence, that usually comes at the last stage for specificity. It comes at the last stage, like when there is a complete. So we're not really looking into this now. In the case of suspected case of Cauda equina, we're looking into some, let's say, the leg pain as far as the sensitivity is concerned. So when we've got a patient come in with back pain, with unilateral or bilateral leg pain, suspect Cauda equina, especially seen, or based on this, sensitivity is 0.43, reduced anal tone 0.3 with sensitivity, urinary retention 0.25 sensitivity, but then specificity is 0.72. So you've got to just check and see which is with what are the symptoms that this patient is presenting with. Is it a case of suspected CES? If it's a case of suspected CES, then it's an urgent referral, because there is no wasting of time. Usually it's within, if it's a case of if it is a case of suspected CES, then it should be within a time frame of 1 to 2 weeks from zero, like 14 days. Because it is said that, like according to the according to what will I say? According to evidence that CES, if it's up to if it is past 2 weeks, then less likely, on patient presenting with all these symptoms, it's less likely Cauda equina, because at 2 weeks, then if it is Cauda equina, complete like damage must have already been done. But if there is no damage, then it is less likely Cauda equina. So another reference here said only around 10% of patients with suspected CES have positive MRI findings. Now, in the UK, we've got this GIRFT pathway for CES. So it's like a guideline that once we've got a patient that comes in and we are suspecting CES, then this is what we're supposed to do. So it looks somehow like this. The GIRFT guideline emphasizes that one suspected CES is a spinal emergency, definitely. And what is it that we look out for? Any new bladder dysfunction, saddle sensory changes, bilateral neurological symptoms, or progressive weakness in a patient with back or leg pain should prompt an urgent referral for MRI and specialist assessment. So I've got a link here. So we just go in, sorry, I'm just going to just do that, and then we just go into enter. Yes, so at the primary level, presentation at the primary level, because I'm in the primary level, so just go in there. So have you considered alternative serious causes for back pain or leg pain? Yes. So we have to also consider other causes of this back pain, or we're not going to see once a patient just come in the back pain, we're just going to know this is a CES. So we've got to screen for other causes first. If yes, then we go this way, and if no, then we go that way. That way will give us information about how to review for community red flag, obviously. And if yes, then we have to follow this. Has the patient developed any of the following in the last 14 days? Like I said, it has to do with the time frame. So any new or deteriorating difficulty in initiating micturition or impaired sensation in urinary blood flow, which may lead to incontinence. Is there any new or deteriorating altered perineal or genital sensation? That's following the S2, S5 dermatom. And for here, I think sometimes we get the GPs in our practice, we get the GPs, if we're suspecting, we get the GPs to help us check with the anal tone. It's out of our scope to do that, so we just get the GP. Usually there's on-call GP or the floating GP, just get him. This is what I'm suspecting. I want you to please help get the anal tone for this patient, and then we'll be able to, reach on your conclusion. And severe or progressive neurological deficit of both legs, such as major motor weakness with knee extension, ankle eversion, or foot dorsiflexion. We should also think about that. And then new, in less than 14 days, or deteriorating loss of sensation for the rectal fullness. Yes. New or deteriorating sexual dysfunction. If all is yes, then we follow this. And if all is no, then we follow. If any is no, then we also do, based on our own clinical judgment, we look into what to do next. So then if yes, then we refer to the nearest hospital for here, depending on the pathway. Again, we've got different locations. So depending on the pathway, you've got to refer for same-day emergency. You have to document what is it that you saw, what are the symptoms, what is the frequency, what is the duration, the time frame, the progression. Is it like the same since the past 7 days, 8 days? Is it getting worse? Is it getting better? You've got to document all that. Time and date of assessment, so they can also look at the time frame of your referral, time of referral, person receiving the referral, and the advice received and from whom. So usually when we see the case of suspected CES or any other spinal pathology, or even any condition at all, we've got to do what is known as the safety netting. So we suspecting this is what we need to do. We need to educate the patient on other red flag signs that if they see, they should seek for urgent care, or if at all they don't even have the sign and symptoms, after our plan, we still have to safety net the patient in case at this moment you're not having this, you're not having that. But in case this condition change, you've got this, you've got that, we've got to mention all those red flags, then you have to seek for urgent medical attention. So we've referred patient to the secondary care. Patient is no longer with us. It's with the secondary care to continue with the management. And yeah, that's it. I think we're going back to our presentation. So the golden nugget for CES is the age. So as we should think about CES in age 30 to 49 years in females are more. We should also, if a female, mostly females coming age of 30 to 49 years, we should make sure that we screen completely for Cauda equina. Bilateral leg pain should increase suspicion. Unilateral leg pain, we should suspect, but once it is bilateral, it should increase our suspicion. Reduce ankle reflex, sorry, I didn't put that. Saddle anesthesia. Always consider urinary tract infection or benign prostatic hyperplasia as a differential explanation for urinary symptoms. So again, one other thing, if we've got a patient that have got changes with urinary function, we've got to think, could it be as a result of urinary tract infection? If the patient is, could it be as a result of benign prostatic hyperplasia, especially that is in the men? So all this we have to all look into before we can really conclude that this urinary dysfunction is coming from, it's of spinal origin. Then we move into another one, which is the degenerative cervical myelopathy. It is a clinical syndrome that results from spinal cord compression, but at this point, not in the lower region, in the cervical region. It is often due to spondylosis, disc herniation, hypertrophy of ligamentum flavum. And what are the clinical presentations? So we see a patient, we think it might be degenerative cervical myelopathy. What are the presentations? Well, there are like four things we look into. We watch out for the upper limb, the lower limb, we watch out for neuro symptoms, and then we look into other factors. So with the upper limb, we're looking out for hand clumsiness. So patient might still come with radicular pain down the upper limbs, but that's not what we look into that. But if we're suspecting degenerative cervical myelopathy, then it has to do with the hand function. So hand clumsiness, reduced dexterity and fine motor control. Usually it is bilateral. So we see one, less likely it might be, you see unilateral, less likely it might be degenerative cervical myelopathy, but with bilateral, then it should raise our suspicion of degenerative cervical myelopathy. The wider base of support, when we're talking about the upper and the lower limb, we see like a change in the gait pattern, patient coming with wider base of support, shuffling gait, spasticity, or unsteady walking, then that should also raise our suspicion might be degenerative cervical myelopathy. Then we see radicular pain, weakness, muscle atrophy, and sensory loss. These are the neurological function. These are the neurological symptoms, but then it's usually not acute, like not at the initial stage. Usually it's towards like when it's more advancing. Then we look into also other symptoms that we might see. Other presentation are the neck pain, neck stiffness, shoulder pain, or even lower back pain. Now, what are the examination that we need to do in the clinic when we've seen someone presenting with such condition? We look into the gait. As I said, upper limb, lower limb, we have to look into. With the lower limb, we look into the gait pattern, do the tandem walking, Romberg test, coordination. We check in for coordination and proprioception. And with the hand, we look specifically for hand atrophy and loss of dexterity. Atrophy towards the end, but the first sign we're looking out for is dexterity. How is the dexterity? Then we look into the open-motor neuron testing. We do the Hoffman test, the inverted supinator sign, Babinski sign, and the clonus. Now, the upper motor neuron testing are specific, but they are not sensitive in the sense that if we do all these tests and they are positive, it's not a complete, it should raise our suspicion that an individual might have a case of degenerative cervical myelopathy. They might or they might not be having. So it's just if we've got all this, then it should raise our suspicion. Then usually it's very much important for us to go for cluster finding. We shouldn't base our findings on one aspect, like looking only into the gait or the upper limb symptoms or the lower limb symptom. We should look into other things. Cluster findings gives better results. So we look in gait deviation, positive sign, Hoffman sign, inverted supinator sign, positive Babinski sign, and the age of the patient, usually above 45 years old. If an individual have got 3 to 4 out of this sign, then the probability of degenerative cervical myelopathy will be around 94 to 99%. So we should think more with the cluster finding. We should base our clinical decision with the findings. DCM is a most common cause of spinal cord dysfunction in adults, but then it's usually missed, especially in the primary care. We've got the MGO classification for degenerative cervical myelopathy. It's an outcome measure that scores it's an outcome measure that is used to assess the severity of the cervical myelopathy. So it assesses 4 key areas: the upper limb, the lower limb, and sensory function, and also the bladder function. So when we look at the upper extremity motor function, point from 0 to 5, it's evaluate the ability to eat, the use of chopsticks, spoon, and movement of the arm. Basically has to do with dexterity. In the lower extremity, scoring 0 to 7 points, it's evaluate the gait and stability ranging from no function to unable to walk. And then upper extremity sensory function, assessing for neurological deficit, assess for numbness or dysfunction, and then for bladder function, 0 to 3 points, assessing for incontinence and retention. So the score. The lower the score, the more the severity of the cervical myelopathy. So if we've got a lower score of 0 to 11, it means this is a severe case of degenerative cervical myelopathy. If got like moderate score of 12 to 14, that's a moderate one. And 15 to 17 means it's a mild case of degenerative cervical myelopathy. So for severe and moderate, it's usually cervical decompression. So it's usually surgical intervention. Mild one can be managed conservatively based on the clinical outcome of assessment, like the presentation, how the patient has to, sometimes we have to like closely monitor the patient, making sure that they don't fall into that moderate to severe at when we just discharge them. So we have to kind of keep an eye on those patients. Of course, has to do with spinal impute. So compression fracture. So sorry, I wanted to show you how the it looks like this. This is a modified Japanese orthopedic association scoring scale for degenerative cervical myelopathy. Maybe when I share the slide, then you can go over it. And then, yeah, that's it. That's just a quick one. So we move to the next one, which is compression fractures. Like I said, unstable fracture, usually not seen in the primary care. It's usually as a result of significant trauma. So mostly it's going to be secondary care. But compression fracture can occur when there is collapse of the vertebra, mostly common due to osteoporosis or trauma, and it's resulting in structural instability and acute spinal pain. What are the symptoms? Patient presenting with sudden onset back pain, pain worsening with lying down flat because of increased axial loading on the vertebral body, and sometimes you see patient, there is like kind of reduced loss of height. So patient might develop kyphosis. What are the physical examination? Localized tenderness on palpating the affected vertebral area, reduced spinal mobility, obviously because there is pain, so there will definitely be reduced significant pain. Then that can reduce spinal mobility, but particularly with extension. So given the patient or given the individual that thoracic kyphosis kind of posture. So postural changes is another thing that we look out for. Once we see patient with postural changes, thoracic kyphosis, then we suspect vertebral compression fracture. Suspect compression fracture. If we suspect compression fracture, then it's considered as an urgent referral for X-ray just to confirm it, and also we should consider assessing for bone health. Compression management in the primary care is first we look into risk factors and action. So age, 65 and above, osteoporosis, long-term use of steroid, then we should think compression fracture in when we've got these risk factors. When there is trauma, even if it is a mild one, like even if there is no trauma, we should think about stress fracture in individuals that are osteoporotic, females usually osteoporotic, age above 65. Stress fracture can cause spinal pain. Arrange for urgent spinal X-ray, where we're suspecting there is a spinal fracture. It's an urgent referral for X-ray, and then we also assess for osteoporosis risk and optimize analgesia and referral to the spinal team. X-ray management. So X-ray.
Hello, good evening.
Hello.
I said I hope you no forget about the short quiz.
Yes,
that we
yes,
say
don't worry.
it is
After this, that's the next one we are coming to. I'm not
Thank
forgetting.
you.
Sorry. So
Thank you.
X-ray initial imaging to confirm the fracture, and then blood test, bone profile and myeloma screening, pain optimization, bone health management. And we also consider osteoporosis clinic referral, DEXA scan, all this arranged within the primary care. Indication for surgical intervention. So when there is acute fracture, patient is unable to mobilize because of pain, or when there is sign of acute neurological deficit, then cannot be managed. We shouldn't only consider conservative management. We should consider surgical intervention. Definitely that is by the spinal unit. So compression fracture are common in older adults, particularly those with osteoporosis, and may be present with sudden severe back pain. So yeah, this is the case study. So I've got 3 case studies. I don't know how we are going to do it. So am I going to say it out, and then maybe 1 or 2 persons will say what they think about, or they will utilize the chat box in chat to get the view of some of us. So this is the first case one, a 76 years female, 2 weeks, presented 2 weeks history of low back pain after turning in bed, 1 week history of left lower limb pain, reports left ankle dorsiflexion weakness, no bowel and bladder symptoms, no saddle anesthesia, past medical history, type 2 diabetes and hypertension, but then all control. And on examination, there is reduced light touch sensation in the left L4, L5 distribution, and there is motor weakness L4, L5, which is 2 out of 5, a positive SLR, reproducing L4, L5 pain, upper motor neuron signs negative. What is your thought about this patient, and what will you do? What do you think about this patient, and what will you do? Oh, sorry. Hello? Hello? Are we going to
We are
use...
here.
We are
Okay.
here.
We
can
don't
hear
know. Are
you.
we supposed to answer you individually or in the chat box?
I'm not sure, just maybe someone just give an idea. Do you have any idea what might be going on, and what is it that what do you think you will do? Like if you are in the case, you are the first contact and a patient presents to you like this, what will you do?
Hello, ma.
Yes.
Are you talking about the quiz that it is going to be individually or what, ma?
I just want us to discuss about this patient. Let's say
Oh,
what is just it's okay, just say 1 or 2 things and we can just move forward. We don't have to kind of waste time. It's okay. Just say 1 or 2 things. It's so it will not look as if I'm the one doing all the talking. And this is a kind of interactive.
okay.
Can someone hear
Okay,
me,
thank you.
please? Can anyone hear me?
Yes, we can hear you, sir.
Thank you very
Can
much
hear you.
thank you very much for the presentation. Given the case we have with us, a 76-year-old female with 2 weeks history of low back pain, which is pointing towards an acute onset, no bladder or bowel symptom, no sudden anesthesia, with ankle dorsiflexion weakness. Also has comorbidities. This is looking like a foot drop of spinal origin, since the onset here, the causative factor that she is pointing towards is that she turned in bed. So maybe she's already has osteoporosis that was not diagnosed. So that turning could have caused an injury to her spinal structures, which might be presenting with giving us these symptoms. She looks like a candidate. She's not a good candidate for surgical intervention because she's a type 2 diabetic patient and hypertensive, even though it's controlled, but might still be dicey given her advanced age. So in my case, we might look towards giving her neuropathic medications because she's already advanced in age. So we're trying to manage pain as much as possible while we proceed with the physical therapy intervention of managing her symptoms. Thank you.
Good, that's an excellent one. And yes, you did got it. It's this is actually a real patient. My senior colleague saw her, and yes, it is a foot drop case of spinal origin. And shared decision making was made with the patient. We explained the surgical intervention and the conservative intervention, and the patient opted in for conservative intervention, and she came off it fully recovered after some months. So yeah, it's a foot drop. So this is where the patient preference also come in, and it's also a case where we look into those two factors, that two indicators for surgical intervention: the onset and the pain. How severe is the pain, and what is the time frame? She falls into 2 weeks. Yes, it's within the time frame, but then the severity of the pain, it all depends on the patient. If it's something that they will, patient preference, no, I cannot manage this, and with other comorbidities, that type 2 diabetes, although under control, as you said. But yeah, that's a good one. Thank you. So the second one, let's quickly move. Sorry, that's it. 54-year-old female presented with sudden onset of 1 week low back pain. She described it as heaviness in the lower back. 4 days history of urinary urgency, frequency, and dysuria. She reports poor urinary stream with intermittent dribbling in attempt to void. Mild suprapubic discomfort, no leg pain, bowel dysfunction, and saddle anesthesia. Systemically well. She's afebrile. On examination, no obvious lower limb neurological deficit and no objective motor weakness in both lower limbs. What is your say? Like, what do you think of this patient and what will you do? Again, just one person can just volunteer and then we just have it and we can just move forward. What do you think about this second case, and what will you do if you are the first contact physio? Hello, anyone? Or should I just move on?
Okay, ma. I personally suspect that this may be a case of Cauda equina. I don't know. The history makes me suspect such.
Okay, in the history, what specifically makes you suspect Cauda equina?
The part about urinary urgency and something about inability to void, if I read correctly.
Yeah. So it has to do
In
with
attempt to
urinary
void.
function, yeah? Urinary dysfunction, yeah? So urgency to void, poor streaming, dribbling in attempt to void. So you
Yes,
are thinking towards CES. Do you have any other differentials? What will you think? What else do you think can cause this symptom? Any other thing that comes in mind, anything at all? Might be MSK, it might not be MSK, anything at all. You might want to screen for something, anything.
I can't think of anything.
All right, that's
urinary tract infection.
I want to screen for UTI.
Yeah, that's it. So when we've got individuals, patients that are presenting with back pain, with urinary dysfunction, we've got to screen for UTI. So is it because of UTI? Is it because of other conditions like prostate issues? So all this we've got to screen out for. So with this patient, it's a case of urinary tract infection, but it mimics somehow the case of like evolving CES, right? But she does not have leg pain, no obvious neurological finding. Yes, she was referred for urgent MRI, but then it came out just some mild degenerative changes in the lumbar region, no spinal cord compression, no cauda equina compression. She was managed conservatively, and also urinary tract infection was diagnosed. She was also, so it's a kind of co-management, medical wise, GP managed urinary tract infection and conservative management, MSK related back pain. So yeah, we've got to screen and we've got to act based on what we've seen. Okay, that's a good one.
I wanted to point out the heaviness in the lower back. Is that something that is common with Cauda equina syndrome as well?
That's how she described the back pain. So patient will come in with back pain. We should suspect if patient is coming in with back pain. Back pain, change in urinary function. When there is unilateral or bilateral leg pain, that should raise our suspicion. When there is saddle anesthesia, has to do with numbness around the front or the back passage, this should raise more our suspicion for cauda equina. But in this patient, it's more the urinary dysfunction with the back pain, and she describes it only as like heaviness, which can happen even in mechanical back pain. So obviously it's not like a severe pain to her, so she just said it feels a bit of heaviness in my lower back, so it's not severe back pain. Although when you look at it again, she fits in the time frame 1 week, so we definitely have to suspect Cauda equina based on her presentation. So that's why it's very important for us to screen all out. So it's not that kind of, okay, watch and wait. Once we see some of this, once we suspect this Cauda equina, it's just a straight away emergency MRI. Just do the MRI. Let's see what is happening. Hopefully, if it is not CES, then we manage conservatively. But if it is CES, then it's a spinal emergency, surgical intervention immediately. So yeah, should we move to the next case?
Sorry, ma'am. I want to also ask
Yeah.
this.
Yes.
Shouldn't we also try to find out the history and find out if this patient is diabetic? Because I think diabetes can also cause something like this.
Thank you. And that's one thing I had wanted to use as an assessment, like, yes, to see. I did not include any of her past medical history. I had wanted to ask, is there anything else that you would love to know about this patient? And that's one thing. For this patient, she doesn't have any comorbidity. I just put it sorry, I wanted to see if we are getting like, and I forgot to mention it, and I forgot to ask as well. Thank you for bringing that out. And that shows that, yes, you're really with us, and you will be a very good FCP because you will definitely look into all the aspect that needs to be looked into. So she doesn't have any comorbidity. So that's it. Are we good? Can we move forward? To the next case, 68 years old male presenting with severe neck and upper thoracic pain. No history of trauma, but pain started after movement on bed as well. Pain is constant, worse at night, not ease with rest. Report feeling feverish and generally unwell. Recent urinary tract infection treated 2 weeks ago. 1 week history of hand clumsiness and unsteady walking. Past medical history of type 2 diabetes mellitus. On examination, there is marked cervicothoracic tenderness, grossly restricted neck movement, brisk reflexes in the upper limbs and the lower limb, positive Hoffman sign, unsteady gait. What do you think about this patient and what will you do?
This patient is likely to have had a degenerative spinal myelopathy from the presentation, the age of the patient, and we're talking about clumsiness of the hand, and then there's worsening of the pain at night. And then I kind of sort of suspected spinal infection because of the fever. I'm not very sure, but that's my thought. And then you're talking about Hoffman sign and the rest of the reflexes going down Babinski and the restricted neck movement.
And the
So
previous urinary tract infection treated 2 weeks ago.
Yeah.
Yes, and that's a good one as well. Is there anything else you would want to know more about this patient? Anything else I might have missed? Anything? Just check. Anything? I think there is nothing, and it's a good observation and a good clinical reasoning. So according to the age of the patient, I will think towards degenerative cervical myelopathy, but of course, with the history of urinary tract infection, feeling feverish, generally unwell, I will also think spinal infection. Yes, it was an infection, but then advanced causing myelopathic myelopathic compression in the cervical region. So patient was referred for GP review. GP did the review, infection was present, MRI was also done just to see what is really happening, and then it confirmed a compression, and then patient was referred to spinal, it's a referral to the spinal team. So it's a very good thing.
Sorry, I
Like,
have a question.
yes,
So are we considering also the blood markers when we are talking about spinal infections?
yes, of course. So if
Like
you're
looking at
thinking,
the CRPs and the ESR.
yes, if you're thinking infection, then you have to liaise with the GP, depending on your own pathway, depending on where you are, your clinic, how you operate. So you have to liaise with the GP, or if you're able to request for the blood tests, you will just request for that, look into that. But again, one thing that you need to put in, because it's a case of serious spinal pathology, then it's urgent, and that's urgent MRI, urgent spinal referral. So you will not waste time waiting for the blood test to be back. Depending, to be honest, depending on the pathway, depending on how urgent they might respond to you, with the blood test. So the best thing is just urgent, same day emergency for spinal. So definitely you have to do the referral. And that's where the documentation come into play. You have to document whatever it is that you see and what is your concern. That will make the person receiving it to act more promptly as well. Because anyway, we're going to get that. We're just going to move into documentation. So we'll look into that. Is that okay? Are you okay? Can I move forward?
Yes, I'm okay. And again, do physios also refer for MRI in the UK?
Yes, they do. But actually, you have to undergo some training. As a first contact, we have the right, like, yes, we are authorized to refer for MRI. We can refer for urgent MRI. But if I suspect this in a patient, then I call the spinal unit, because we've got a same-day emergency unit as well. So you've got to directly call the spinal unit, tell them what is at hand. They will advise, do this, do that from the surgery, and just get the patient down to us in less than 4 hours. They might just give you like a time frame, just as fast as you can, get the patient down to us, and then just send in a referral via the system, and then already you've called them, so they're expecting the patient. Once the patient get there, then they will just do the needful. They will arrange an urgent MRI, depending if it is for Cauda equina syndrome. They usually, what they do first is they do the bladder scan. So they see the pre-void and the post-void, that will tell them about the function of the bladder, and then based on that, they will now proceed to MRI, and then from MRI, they will now, everything has to be like urgent, everything targeting within 24 hours. Once you do the referral, they will get it. And that's why it's very important for us to do a very good, proper documentation. You don't have to miss, because if you miss anything and someone acts otherwise, then the blame is not going to be on that person. It's going to come back to you, because you did miss that. And the person is expecting you to give him a full case, like a full comprehensive documentation, so he can act fast on that. So if there is anything that is missed, it might really come back to you. So that's why it's very important. Documentation is key in FCP. If you don't document well, it's really going to be a problem. So we can order MRI. It can be an urgent one. If it's a case of like this, it's spinal emergency. If it's a case of wait and see, then I can arrange an urgent MRI. Still, I'm going to indicate this is what I'm thinking, urgent MRI. Probably I might have called the same day emergency, and same day emergency have said, okay, you know what, it's fine. Based on what you've just said, based on what we have on ground, I think we can arrange an MRI from the primary care, make it urgent, and if there is any concerning issue, get back to us. Then we do from the primary care. But if based on our clinical reasoning and based on what we have, they might say, bring down the patient, If it is MRI, we just straight away refer MRI for request MRI for the patient, and you just do it. Everything is on the system, so you just do it, and then patient go for the MRI. They will contact the patient obviously, and then arrange when the patient will get the MRI done. Patient go down, have the MRI done. Immediately, the report comes back to you at the surgery, and then you look into your pathology. You see the MRI report, and then you act upon it as fast as urgent as you can. So, any other question?
Okay,
Yes.
I want to ask.
Okay. Okay, go ahead. Go ahead.
Okay, like what you said, does it mean that the unit you refer the patient to, they will then bank on your own assessment, the outcome of your own assessment to act on either they are going to do surgery or not, or do they actually then reassess the patient again?
Definitely, they will have to reassess. My own is for them to know what they are, like what is coming to them. So they get a kind of prepared. So once it comes to them, they look into my own concern and they look further as well. That is the ideal thing. So definitely they have to do their own assessment. So they are not going to only base their clinical decision on what I've sent down to them. They're going to use it to build upon that and then do the right thing for the patient. Any other question?
Yes, sorry. I want you to ask a general question, not specific to any of the case studies.
Okay,
so I understand that when you have a combination of risk factors, symptoms, and signs, and you see a red flag, you refer. So from the perspective of what has been presented today, it narrows down to a condition. So I just wanted to ask, is it necessary that a physiotherapist must also narrow down to a suspicion of a particular condition, or can I just have the combination of risk factors, symptoms, and signs and see a red flag suspecting that there is an organic pathology in a system, say musculoskeletal system, urological system, and then refer? Or is it necessary that I have to suspect a particular condition before referring?
No, sir. So you've got to suspect one. Like, this is my clinical impression. This is what I'm thinking, although there might be this or that. So you can also put in your differentials. If you're thinking patient might also have this and that, all this has to come in your the referral pattern, like documentation. When you're referring, this is what patient is presenting with. Patient have got comorbidity, this and that, and you're thinking your concern is patient has got this, despite the fact that this and that might also be your differentials. You want a review to confirm, or you get, so everything you put in everything in your referral, whatever your concern is. If you've got one differential, if you've got a MSK related impression, you put it down. And if you also concern about, let's say, a metastatic spinal cord metastasis, then you also put in, it might be a compression as a result of metastasis. So definitely oncology will have to come in. So whatever impression you've got, whatever concern you've got to put it down and then do the referral. So basically, sometimes you refer to, you might put that down and then you refer to the spinal team. The spinal team will look into the referral and say, no, this is not a spinal condition. This is for the neuro. The neuro might say, no, this is not for neuro, it is for oncology. So that's why it's very important just to put in what exactly it is that you are concerned about. As a primarily, I'm concerned about this, although patient can have this and that. Like, although I'm also thinking towards this and that. In a way, you are also a kind of protecting yourself. So you're not solely like saying, I'm confirming, because you've not done any imaging, you've not done anything. This is based on your clinical outcome. So you kind of say, you kind of protecting your own neck, so if I can say. So I'm not fully diagnosing that this is what we've got, because we've got other steps to carry before we can reach that conclusion. This is what I've got, this is my impression, but also thinking towards this and that. So it's not only one thing that can be put in the referral. You can put everything that you're so much concerned about, you can put it in the documentation when you're doing the referral. Have I answered that, sir?
Yes, very well. Thank you very much.
Yeah. So can we move now to the subjective? Sorry, the documentation?
Can I go on? Just one question.
Yes, yes. We're good.
So I noticed in all your case studies, when you're talking about pain, you're merely describing the pain. Is there a reason why there's no like scoring for the pain?
So you can put in your documentation, like if you, in your documentation, obviously this is a case study, I might decide to put the pain score or no, not put the pain score, but just presenting with, if you look at it, I did not kind of, based on the NPRS, I didn't say this is the scale, this is patient mentioned pain at the rate, so rate. So I just classify it as mild, moderate, or severe. Do you get my point? So because it's a case study, but obviously once you're doing documentation, you have to ask the patient, you just have to ask, out of 10, how will you rate this pain? Let's say from 0, which is the less painful, to 10, which is the most painful. How will you rate it when the pain is severe? Like when you're really having a flare-up, what is the pain? How will you rate it? And then patient will let you know, and then you will document that. Now, if it ever get eased down, what level do you think it gets to when it is much improved? Then the patient will let you know, and then you will document that. And then at this moment that you are sitting with me, what is a pain level? You also document. So it's a kind of, depending on how you want to use it, honestly, when you're just, obviously for presentation sake, that's why I did not put, but if it's for me to a kind of refer, I can put patient reported 8/10 on a scale of 8/10 when the pain is severe, or at its best, so, but when I assess the patient, so it all depends. Basically, when you're documenting, you have to put in whatever it is that you feel it's important. Just don't miss out. That is the key point. Don't miss out on anything. And when I say severe, I refer, but if, again, that one thing I forget to mention is, because it's a kind of centralized system. So even if I send in a referral, they receive the referral, they're not only going to see my referral letter, like it's not a letter. So they're not going to only see my referral stuff. They have also access to go into the patient's record, and they see everything. So they see my documentation. Probably I must have missed saying patient is 9/10 when I was sending to them, but in my documentation is there for them to see. Does that make sense? So you just don't miss out. Make sure, because everything is just one system. We get access to patient's record, and they also have access to patient's record. Just open it and then you see. So even if you miss out on something when you're writing the referral, but make sure that you don't miss that much. Like you don't miss at all in your documentation. That's just the key. Can we move forward? Are we okay to move forward? All right then.
Yeah, let's go.
Okay, so that's it. We're going to documentation and escalation in primary care. So why do we document? Why documentation matters? Communicate clinical concern clearly. That is what we've been discussing since. Justify the need for escalation. So let's say I just say patient presented with back pain, reported change in urinary function, please review. And I send to you. You'll be like, okay, patient is having back pain. Back pain, everybody can have back pain. Let this patient wait. There is another patient that presented with back pain with radicular symptom in both legs, neurological deficits, blah, like real documentation, full document. There is this patient. So let me look into this patient before I look into that patient. It does not make the person receiving it at the other end to think this is an emergency. Like it does not justify the need for like urgency and need for you to really escalate. So this can still be managed within the primary care. Let it wait. Let me see other urgent cases. Do you get it? So that's why it's very important just to make everything as clear as possible, as like you just have to put in as much as you can. It supports continuity of care. Yes, you've seen the patient, you've documented, and you've gone. Probably you might be there tomorrow, you might not be there tomorrow. Someone else will come and then we'll work on what you've done. Okay, this is where they stop. This is what he's done. This is what he's done. So I can carry on. Let's say for me referring back to the MSK rehab team, I must have safety net the patient. Let them know about Cauda equina in case it is a Cauda equina thing I'm thinking about. I've let them know about Cauda equina. Safety nets them about that. If you see any changes in your bowel and bladder function, if there is any sudden anesthesia, if there is any unremitting, like severe pain in one, if it's radicular pain in one leg, and then if now you're getting it in both legs, please go let me come in for go to the ED, or you come back for me to review again. That's it, you've safety net. Now I refer to the MSK team. MSK team for conservative management. Obviously, they will see my documentation and they will say, yeah, she's done what she's supposed to. She's also safety net the patient in case there is worsening that might prompt like CES, and then patient knows what to do. Do you get it? So it supports the continuity. MSK will still do safety netting, but it's just a kind of support that continuity. Yes, she's done it, so we're moving forward. They don't have to like start letting the patient know. It's obviously time management as well. Do you get? So if you've done what you're supposed to do, the next person will do what they're supposed to do, and it keeps moving. But once you at a point you did not do what you're supposed to do, then it's a kind of give the other person, okay, I have to check all this again. I have to go back, do this, do that, and then make sure that patient is not missing out on this, So it support the continuity of care, promote patient safety. Like I said, yes, patient is much safer. Time management, with the continuity, everything will just be moving faster and patient safety will be much guaranteed. Protect your professional accountability, to be honest, in places, especially where medical legal issue is really serious, then you just have to make sure that you protect yourself, do the right thing, document properly. Document clearly. Obviously, when we take the SOAP, subjective, objective assessment and plan, and when we get to the subjective assessment, like let's take the Socrates. So it's situation. I personally did what is it called? It's like a small, it's like what do you call it? I can't, just within the primary care which I work, I just look into how my colleague do their documentation, look into what is actually missing, and then I decided to work on how we use this Socratic format to do our documentation. I did the I'm trying to remember the word now. Audit. Yes, that's it. I did the audit, and then I realized that some things are some of this are missing, and then we just improve. That's just something that we did to improve, our documentation format. So we look into the Socrates format. There we've got like the situation. What do we have at hand? What is it the patient is presenting with? Back pain, leg pain, whatever pain it is, you just put it down. Onset, since when did it started? Was it a gradual onset? Was it a sudden onset? Like, did it build up because over a period of so period time, just the onset, you just have to document that, the character. That's where we are describing. Is it a kind of throbbing pain, throbbing? Is it a kind of burning? Is it stabbing pain? Whatever character the patient, here they're very good in describing pain. Like they are very good in describing what is wrong with them. So definitely it will be like kind of straightforward for you to be able to do, like easier for you to document. And then if there is any radiation, can be in the upper limb, it can be in the lower limb. If it is associated, if there is any associated factor, now there I've got pain, but then I've got like I'm feeling numbness also in this part of my body, or I feel so in this. I realized that when this pain started, I also have difficulty, in walking. When I'm walking, I'm feeling a kind of not steady. All these are factors that are associated with the pain, then you put it down. And then the time course, of course, you will ask the patient, what's the pattern of this pain? Okay, do you say in the morning, is it more severe in the morning, like after waking up? Does it feel like, oh, I'm struggling to get out of bed? During the day, how is it? Does anything does it change during the day, like with any of your activity, or at night? Do you have pain at night when you lie down? Do you find it difficult to lie on the bed, like lie down because of the pain? Does it affect your sleep? All this, you just ask and then you document it. So I think with this one, recently I got a patient also. He presented, he's around 70-ish. I cannot remember the exact age, but he's around 70-ish. He's got like esophageal cancer. He was treated for it, but then according to the record, he cannot tolerate the what is it called? The oncology, the chemo. Yes, he couldn't carry or cope with the chemotherapy. So the oncology team just advised, okay, since he's a kind of stable, they can get it, they can just watch and see. They did their own part, basically did their own decision making with the patient. They reached a conclusion that they will watch and see. Patient was really losing weight, and then he presented with me that he's having back pain. He's a driver, he's a taxi driver. Now he's coming back with back pain. It's affecting his work. So I looked at him, I did the assessment, every other thing. It doesn't seem mechanical to me. It's more, sinister wise. So what I did was I went to the GP. I called the GP in. The GP did his own medical review, and he referred back to oncology. So there is the possibility of metastasis to the spine causing the pain. He did not present with neurological symptom, but it's more pain. So there might be a metastasis without neurological without neurologic finding. So you see, that is why we refer back to the oncology. Assuming we've got neurologic deficit with the back pain, then we refer to spinal, and then spinal will now liaise with the oncology to carry on with the management of the patient. So it's very good. Just document the time course. Now, it's one of the things that I grab with the patient report pain mostly at night. So during the day, he's able to do one or two things, but at night, that is when the pain is more severe. He can't even, it's affecting his sleep at night. So in the morning, when he wants to go for his normal daily activity, driving, then it's a kind of hard because he didn't have a good night rest and stuff like that. So yeah, it's very important for us to just document everything. Now, what are the exacerbating factors and what are the relieving factors? What makes it worse and what eases it? Whatever it is, you just have to ask. Some patient might tell you that it's seating, whatever the patient say, just try to just put it down. It might not fit in with you, like you might be thinking, how can you say that something like that? Just put it down. That is what patient said. It's making it worse, and that's what he said is relieving it. If it is medication, if it is any positioning, if it is anything at all, just put it down and how severe it is. Now that's where we come to the use of the NPRs. Out of 10, how will you rate the pain when it is severe? Like when you have real pain, how is it out of 10 at night? If it is too painful at night, what will be the severity? How will you rate it? Maybe patient might tell you at night it is 10 out of 10. Then you document it. Severe, NPRs 10 out of 10 at night. During the day, how is the severity? You say it like when it is much easier, it's so. You say it. And currently, when as you're sitting with me, how will you rate the pain? You also document that so that you cover yourself. Again, things that you have to also document is the past medical history, although it is there. So with our own system here, there is somewhere you can just look into past medical history and see what are the active conditions that patient is having, like currently, what is he actively treating, are the medical team actively looking into. You can see what are the inactive, like from the previous, those ones you can also see. So for you to confirm, you have to ask the patient, or from your record, I've got this, I've got that as active. How is it? How are you managing? Is it still then? Oh yeah, I'm diabetic, but it's under control. Oh yeah, I'm diabetic, but the medication is not working for me. I've been changed from this to that. So that's another thing again. You just have to document, because you cannot be scrolling down up just to go like check all the documentation to see. It's just one line that is there, but then that will prompt you to look into that, because that statement has already been there. Ask the patient if there is need for you to seek further, like dig further, then you can easily do that. And then you just have to document. Then we got to the occupation. Like I said, you just have to document again, what is the occupation of the patient? How is the pain affecting his occupation? Again, it's not only about how the pain is affecting his occupation, it's also about the management in the plan. So at the end of the day, definitely you will reach a plan. If the plan is the plan going to help patient, how like what adaptation, what things do you need to change so it does not affect his occupation? And again, some patient might even tell you, oh, I'm a seamstress. Obviously, that's why I've got the pain, because I sit a lot. So that's a kind of yellow flag for you. I have to work on something aside from what I'm having. I also have to work on her idea regarding her occupation. Also check for the social history, drinking, smoking, the home setting, all that. You also document how that also affects. That will also give you an idea about how it affects the health of the individual and how you're going to plan. Let's say you've got individual that you're thinking is oncology stuff, but previous history of cancer. No, let's not use that. Let's say a patient with osteoarthritis, severe one, you're thinking towards that, but the patient is smoking. Then you want to kind of look into how you can refer him for smoking cessation. So we don't only refer for like sinister pathology, we also refer to other units that can help in managing the patient, like smoking cessation, weight management, drink cessation, like help with alcoholism, and for mental health also, if you're thinking towards mental health related issue, you also can do the referral. You let them know this is what you have. So it's a good one, to be honest. It's a lovely role. And yeah, let's move down to the idea. So that's the ice it. On top of everything, you just have to ice it. You've just got to check with the patient, what is the idea? What idea do you have about it? A lot of patients do Google. So I've been having back pain. I asked ChatGPT, and ChatGPT said it's a disc herniation. That's what I've got. So it's a disc herniation for me. Oh, that's what you think you've got. Yeah, that's the idea I've got about my pain. So what are your concerns? Well, I'm concerned. Maybe it's going to stop me from doing this, doing that. I'm concerned about the prognosis. Am I going to get better? Am I going to do this? Is it going to get worse? Oh no, because I've got a family history of cancer. Am I having a cancer? All this, you just ask. Then you will be able to plan more your management when you at the long run. And then what are the expectations? Patient might come in expecting you directly send me for MRI scan because I've got a back pain. Directly, you have to just send me for an MRI scan. But in essence, when you do the assessment, you find out that patient does not need MRI scan. You're not able to meet patient expectation. How do you explain to patient that I'm not going to send you? You don't just tell the patient, I'm not going to send you for MRI because you don't know, because you've already know this is what patient is expecting. So once you're doing your objective assessment, you will want to make the patient, like carry the patient along with you, like explaining each step and letting the patient know this is what we are expecting with this, and if we don't have this, it means we are okay. So it's a kind of reassuring. It will give you that ability to be able to reassure patient that you don't need this. This is what we need, but you just have to reach a clinical decision. Again, you can document it. This is what patient is expecting. But this is what I explain to the patient when you get to your management plan. So whatever comes up, patient might just report you that, no, I wanted this, but he did not give me this. But you've already documented it, that Patient was expecting this, but I explained that because we've got this and this, so at this moment, you're not going to say they don't need it completely because things might change. At this moment, you felt there is no need for this, but explain that if this and this and this, that's where the safety netting comes in. If this and this and this, so and so comes in, patient should seek urgent review. So you review everything and maybe change your mind, maybe to reach the patient expectation. So definitely you have to just put in the expectation. Then after your subjective assessment, obviously, then you move to the objective assessment where you observe. Talking about spinal pathology, definitely we have to observe the gait, most of them presenting how the gait is presented. Whatever gait pattern you see, even if you're not sure what type of gait pattern is, if just mention how the patient presenting, the posture, everything, you just have to document that as well. Then the movement, your palpating, your observation, whatever it is, you just have to put it down, and then you do your neurological testing, and then you document all, and then you do your special test also, you document everything, and you reach your clinical impression. This is what you're thinking based on from your subjective and objective assessment. Obviously, you're questioning it. You're just going to put that out. If there are other differentials, you also put it down. So that's where other differentials also you also put it down. So the first one will be most likely what you're thinking. Then the second next to it is what might be the next one, like based on what, and then maybe the third. So 2, 3 different, one main one, and then 1 or 2 other differential. That's okay. And then what will be the plan? So now in the plan, this is what you do. You discuss obviously the situation with the patient. This is what you presented with, and this is based on our assessment. This is what we've come up with. You've got this, you've got that, or I'm thinking towards this and that. And based on this, what we are thinking, based on the impression, this is how to manage it. We've got conservative management. We've got surgical intervention, which is obviously the last. In most cases, you just explain to them everything. So let them know that this is what we have at hand. This is how best it is at this stage. This is how best it can be managed. And what do you think? So we do a shared decision making. It's not a type of I'm the alpha, I'm the omega. So I just do everything and then patient will just follow. No. You might be doing the right thing and patient will just tell you, no, I don't want. You might say this is what is best for you, and then the patient will tell you, no, I don't want that. And definitely you have to document it. So it's a shared decision making. You don't impose your own decision on the patient. You have to open it out and then some patient will tell you, no, you are the professional. Yes, I'm the professional. I'm here to guide you in making your own decision. So you have to do the decision together. It's a shared decision making with the patient. And obviously, yes, if it's primary care thing, you manage within the primary care, maybe give another follow-up appointment, patient comes back, and then you reassess, review, and see if it's okay for you to discharge. If patient need further input as per physio related, you send. If situation change, then management plan change. Any referral to any other like multidisciplinary team, you just do the referral and that's it. Everything fully documented. No one will come after you. Even if you're on annual leave or anything, your mind will be at rest. Everything is in documentation. When you come back, nobody is going to call you in for any governance meeting that something happened, patient reported you, and yeah. So documentation is the key. And that's it about you documenting in the patient reports. Then when we are thinking we want to escalate, we want to refer, maybe it's not only in urgent, or review for urgent review. It might be just referral to the podiatry, like orthotic to review for like their input in support, like in providing support for the patient. So you just have to follow a format that will be easier for that person receiving the referral to act on. So we can use the SBAR when escalating a patient for urgent review, when we are referring to the GP, the spinal team, or emergency. We can, when handling over consent to another clinician, or let's say I've seen a patient before and I'm thinking, okay, I want a second opinion. Then I can always like send a task to my maybe colleague, say this is the patient I have, although there is the documentation is there, but you just have to kind of describe what you have at hand and then send to the patient, to the colleague, and colleague will look into it, look into the documentation, and also like call in book in with the patient to have a second opinion review. And then so it's a kind of very, like, it's just the key thing, honestly, to professionalism, documenting appropriately, handling over concern to another clinician, making level of urgency explicit. Recognizing serious pathology is not enough. Yeah, it must also be documented clearly and escalated as appropriately. That's in this case. When we look into, so we've looked into the Socrates format, let's look into the SBAR format for escalation. So in the case of is SBAR situation, where are you escalating this patient? So where are you sending the patient to? What is this? Why are you sending this patient to me? I'm sending her to you because I want you to review. Review for what? So you just have to let me know what is the situation that I'm reviewing. You can't just send a patient to me and say, Shafa, to review. Review for what? Why are you sending? Why will I review? Review for what? Just give me a brief summary of what is happening. So brief summary of the situation. You don't have to write like a full page. No, just a brief 2-3 paragraph. It's okay. And then we're done. And then we've got also the background. What's relevant history or symptom progression is important. What is the history? What is relevant? So what is the relevant history and what is the relevant symptom the patient is presenting with that is progressing? How important it is. You just document that. Based on that, what was your assessment? What did you do? Actually, you can't just tell me to review. What did you do? I'm not just like a dumping refuse. You must tell me what you've done before you want me to review. So that's where the assessment come into. You say what you've done, what did you find during your examination, and what are your concerns? And then what is your recommendation? Then you're recommending me to review. What needs to do next? What do you want me to do? Like, review for what? Review because you want me to review, or review because you want me for further management, review for further assessment and management, review for MRI, review for input regarding use of suitable authority, review for what exactly? So you just need to tell me what needs to happen next. Like, what do you think? It might change, but then you just have to say your own opinion first. So again, just let's have a format. I don't want to say a bad format, but I don't know how to say it. So it's a bad format. Let's just take an example. Patient has low back pain and some urinary symptom. Pain goes down the leg sometimes, feels numb occasionally. Kindly review. What do you think is missing here? Maybe one or two. Just chip in. What do you think is missing? What needs to be added? Like any idea, anything?
Assessment.
Too
No assessment
unspecific.
was done. There wasn't any assessment that was done.
The duration.
Yes, and it's not specific.
Mm.
And there's no impression.
Saying some urinary symptoms seems vague. What exactly were the symptoms you saw?
Feels numb occasionally.
What's the impression?
Yes,
It's
impression.
not objective. I think it's
Also, there was no recommendations from the
of the patient. And what
from the
differential
referral.
do you have in mind?
So we don't have like a very good, like a kind of history or background of the patient in this condition. And pain goes down the leg. Pain goes down the leg, and sometimes pain goes the leg sometimes. So what pain, that might be a radiculopathy. That can still be managed in the primary care. Why are you sending her to me? I'm in this spinal team. Why are you sending her to me? This is something that if it's this county, I think it's something that we can, if it's a urinary symptom, Urinary symptom, you can do something, maybe screen for UTI. If it's not concerning, then what exactly is the symptom with the urine? Urinary symptom, how will I know? Is it incontinence? Is she straining, like, is she trying hard to void? What is it? It's not even a she or he. I don't even know if it is a he or she. So, do you get my point? I don't know what is the age I'm even working. I'm in the I'm in the secondary care, and sorry, I'm in the primary care. I see patient 16 and above. I don't know if this patient is even 8 years, and you're trying to let me like review. Do you get my point? So you just have to put in as much information as possible. So let's just look at a kind of good format, so to say, somehow, at least much better than the other one. So we've got a 54-year-old female with 1 week history of low back pain, described as heaviness across the lumbar spine. Over the last 4 days, she has developed urinary. So you see, you're telling them like a history. Over the last 4 days, she's developed urinary frequency. You see the symptom of the urinary symptom. The dysfunction here is coming out: frequency, urgency, poor stream, and intermittent dribbling. She denies bowel and bladder function. This is to let them know that you've screened for CES, like you screen for CES. She denies bowel dysfunction and saddle anesthesia. So you're less concerned about, like, you kind of telling them, okay, I'm thinking it's not CES stuff. No leg symptom reported. You see, that's another symptom that's another thing that will raise our suspicion for CES. Unilateral, bilateral, in most cases, bilateral will raise the CES. If it is no leg symptoms, if it is one leg symptoms, definitely you will see right leg symptom, reported right leg pain. If it is bilateral, you've got to see reported bilateral, whatever. If it is left or right, you just have to also indicate. Symptoms are concerning for possible evolving Cauda equina syndrome. Now, despite overlapping urinary differential, so this is where I think, sir, this is where your question comes in. I'm thinking Cauda equina, but she's got overlapping urinary differentials. Urgent spinal assessment and MRI recommended. This is what I'm thinking should be our next stage. Patient is advised, so I've safety netted the patient. I've saved my neck. Advised to seek immediate medical attention if symptom worsen, particularly new saddle sensory changes, bowel disturbance, or increased difficulty voiding. So I can say safety netted the patient, and then the patient will come back, something went wrong, and then they will go to my documentation and say, she said, you said you safety net the patient. I'm like, yes, I safety net the patient. So what exactly did you say in your safety nettings? Sometimes we argue that time. But you come here, you find that you've got all the time, and all this is going to be in 20 minutes, and you just have to do it. So you see the patient, you do the clocking, you do documentation, and you do the planning all in 20 minutes. Although you've got some admin slots, obviously, when you're not done with some other things, you can go back and always complete it. But it's not about the time, it's about being deliberate. And once you start like proper documentation, to be honest, you wouldn't want, like, you wouldn't want to miss it for anything. It's the most sweetest thing, I would say, in the role, the documentation. Once you're doing the document, you will feel that, oh yeah, you feel like, yes, I'm really doing what is needed of me. Like, yes, I'm really, that professionalism, you really feel it. So what do you say about the good format? Anything maybe I have missed again? Maybe. Hello? Sorry, I've taken too much of the time. It's supposed to end by 6:24, but yeah, I promise you we're done already. Hello? Can you hear me?
Yeah, we can.
Okay.
Yes, ma'am, we can hear you.
Okay, everything that I might have missed again with the good format, maybe I might have missed something someone can see. So assuming someone sent this to you and then or what will you think? I think you will act urgently. You will act urgently. So even if you've got other patient in your list, you will want to see how to stratify, you just how to fit in this patient so you can review urgent. You get, so any input, anything? Are we good? Can I move forward?
Yes, you can.
All right. I think we're done. So what are the key take-home messages? Not all spinal pain is benign or mechanical. We should always think otherwise. It's not all back pain that can be managed conservatively. We just have to look, make sure we're not missing out anything. Red flags are only useful if they are actively screened for. Now, the red flags are there. If we don't check, we can't see them. Some of these red flags, the patient don't know about it. So you don't expect a patient to come and tell you, I'm having back pain and I'm finding it difficult to pass urine. Some patient might not think it's related. Educated patients or like patients that care to know, sometimes Google, they might know, but they would not know the red flag. You are the professional, you know the red flag, so you just have to screen for the red flag. You have to let the patient be aware that if this is happening, we need to do this. We need to, some patient, you might be asking them some question and they'll be like, why are you asking me? Especially with the sexual dysfunction, I'm having back pain and you're asking me how am I getting, how is the sexual function? It's back pain that I'm here for, but yes, it's important for me to know because it's a red flag. If that is present, then it might be this, it might be that. So you just have to let the patient don't know. So red flag can be there in the guideline, but if we don't use it, it's not useful. Clustered symptom often matters more than isolated findings because we've only got urinary symptom, then it's Cauda equina. No, look into other things, cluster findings, then that will kind of give you a better picture of what is happening. Document clearly and escalate early when necessary. I cannot overemphasize the importance of this one. Good clinical reasoning become visible through good communication, good documentation, sorry. So once anyone see your documentation, they will know that, yes, this is a professional. The clinical reasoning is sound like, yeah, this is good. The patient will be more confident if they are to, yes, they are to look into the documentation. Here they have access to their records. They can always open and see what did they do. Like, and you might be like, okay, I said this, you might document that you did all and you did not do with the patient. Patient have got their record, they open it and they see, okay, documented that I did this, I checked for no nil bowel and bladder function. When did she ask me? When did she ask me about my bowel and bladder function? No, this is impossible. Reporting. So you just have to do it and then you report it. You don't have to say because of time, oh, I forgot, I did not even. No, just once you do it once, twice, 3 times, before you know it, it's become part of you and it just keep flowing. Just keep improving, and then we're good. So good clinical reasoning is more visible through. And then when the patient will get to come back again, they will be like, oh, I want to see that same person because they feel more safe with you because they know, that person is doing just the right thing. Whatever transpire between me and her, that's what I'm seeing in the documentation. Thank you. And any questions? Anything at all? And that's it. That's the end.
Thank you so much, Ma, for your presentation. I have a question actually. So when you were talking about the common spinal pathologies, and I don't know, when you mentioned all the conditions you were going to talk about, something came to my mind. I was thinking of transverse myelitis, and I wanted to know, could transverse myelitis be classified under spinal infections, or would it be a total condition on its own? And how does it fit in with this kind of presentation?
Transverse myelitis. So with transverse myelitis, what is the patient presenting with? That's one thing that you look into. What is the patient presenting with? like any back pain, screen for any spinal origin, any spinal cause. Like if you feel with transverse myelitis, it's not MSK. That's not MSK related. That's more neuro. So we are expecting you to refer to neurology. Do you get? So it's not my, according to the scope of practice here, once it is not MSK, then I'm not managing MSK. I'm not going to say, even if I'm thinking transverse myelitis, I will write it down. This is my, this is my, like the S-bar format now. You just do everything and then you just refer. I've screened this patient for possible MSK related, but it's most likely transverse myelitis. So I'm referring to I'm referring to the neurology. Does that answer your question?
All right, thank you very much. That does.
Thank you, Ma, for the wonderful presentation. Please, can we get the slides?
It's okay. I think I'll just speak with the organizer and then he will get back to you anyway.
Okay, thank you so much. Have a nice day, Ma.
Thank you.
Okay. Thank you, ma'am, for the wonderful presentation. My own question is, when you were talking about having issues with bowel and all that, you mentioned something about sending to the GP for checking the anal tone. Does it have to do with your own area of expertise? Since you're in musculoskeletal, it doesn't cut across, because I know pelvic and women's health, they check anal tone and all those stuff. So when you said that, it crossed my mind that I would have to ask you later to know why you are referring out, or is there a special equipment they use to check it there?
So, to be honest, there's no special equipment that they use to do the checking, but based on the scope of practice here, you cannot do I can't do your work and you can't do my work. It is your work and you are to do it. It is my work and I am to do it. So if there is anything like that, it's just the GP. It's just the pathway. It might be different back in Nigeria. So if you can do it, if it's okay for you to do it, if you can do it and you will get the tone correctly, everything, you will just document it. But here, usually what we do is we just get the on-call GP to help us look into it, or sometimes the nurses. So it's just about the pathway, like depending on where you're practicing.
Okay, thank you so much, ma'am. It was a wonderful presentation.
I have a question.
Thank you.
No?
Okay, ma'am. So thank you for your presentation. I mean, it's so insightful and wonderful. Thank you so much. I have a question regarding the red flags we talked about, the spinal infections. So, considering that, is there need to, because we're talking about infections and TB could also affect spine, is there a need to ask about history of travel? That is one of my questions.
Yes, you've got to. If you're thinking towards tuberculosis, well, here, obviously, you have to. You just have to ask whatever question that you think. You in the clinic with the patient, you've seen the patient, like you're seeing the patient. Most likely, patient recently traveled, any recent travel, if you're thinking, if you're within, even if you're not within that area where TB is like high, you still have to. You just have to. You can just ask anything askable and then document it.
Okay.
That I've also
Then
done.
My second question is regarding these red flags we are talking about. Is there another they need to ask about inflammatory polyarthritis, like you have the autoimmune causes also?
Yes. Ankylosing spondylitis, yes. So, yes, you just have to. You have to. So when we talk about ankylosing spondylitis, I think what we've presented, our next presentation will have to do with rheumatology stuffs, inflammatory spondyloarthropathies. I think you will, I'll be able to answer more when we get there. But still, you've got to screen out. What we are looking for here is serious spinal pathology that require urgent action. Do you get my point? So we are talking about, when we are talking about ankylosing spondylitis, unless if patient is presented with neurological progressively like worsening neurological deficit, then I don't think that is like same day urgent. Does that make sense? It is concerning, but it's not urgent. Does that make sense? Do you get my point?
Yes, I get your point. Thank you so much.
Yes, good. Any other question?
So yellow flag, right? Red flag, yellow flag. No, go ahead.
Okay, so I don't know if I missed it, but when you were talking about metastasis for cancer now, there was no question on weight loss. Is that not a thing anymore?
You have to ask. I missed that. Yes, I missed that, but you have to ask. So if there is a previous history of cancer, obviously you will ask about the weight and you will also check the weight. So you will ask about the weight. Do you feel there is a decline? Like, are you losing weight also? Even if there is no history, previous history of cancer, you still check with the patient. Maybe the patient might have cancer and they don't know. But again, when we're talking about weight loss, we're talking about not say 1 kg in like in like 10 months. We're talking like serious. I can't remember the actual weight the actual reduction in weight that need to be considered when we're talking about weight loss in case we are thinking about spinal metastasis. But also I think that will also be very much in our next presentation. We're going to discuss more about that. But yes, you just have to ask for weight as well. So you ask for weight. If there is any weight loss, you document it. Patient report weight loss over the past 3 months or over 2 weeks or whatever time frame it is. Weight used to be this, but report have dropped to that. And then for you to confirm, you've got to tell the patient, go on the scale, let me check, and then you document. So yeah. Any other question?
Yes, thank you very much for the wonderful presentation. I just wanted to understand the model of practice, FCP, over this. After assessing for all these, what are the actions that you actually carry out? You just escalate, or you're also involved in the management of these conditions?
That's what I said in the initial. Maybe you missed the first part of the session. So you assess, you reach the diagnosis. If it's urgent, you refer. If it's not urgent, if it's something that you can manage, that means it's something that can be managed conservatively. You can start management from the primary care. Now, with FCP, we don't usually see patient as much like routinely. Does that make sense? Like we do see, but in very rare conditions. Like there are some patients that will say they prefer to come to you so you can carry out, like you can carry them along during the rehab process. So like because of the timing as well, 20 minutes, I don't think it's enough for you to always do, the rehab program with them. So we do refer them for MSK physio. So with the MSK physio team, they're the physiotherapists there. It's sometimes they organize like exercise sessions, circuit exercises, leisure centers, the MSK in those places that we refer to, and then they carry on with the rehab. However, if it's something that you feel, this is osteoarthritis, it can be managed conservatively, modifying activity, modifying lifestyle, give some exercises. You can start with in the primary care, and then you can book a follow-up with the patient. Patient can come back, let's say in 6 weeks. Obviously, if here they are very much good in being consistent with their exercises and with whatever plan you put in place for them. So come back, review again if there is progression, like if there is improvement, that's a good one. You can progress their exercises, and then you can finally discharge them when you feel they are good to go. And then you can always let them know it's open. You can always come back and like you can always refer back if there is any other concern, or if you feel anything change within any time, you can always come back. However, if you feel, okay, patient is not going to be able, is not going to cope with that exercise, with you coming back, just refer them for further. So there are groups. They've got, it all depends on the area which we are, to be honest. In this area where I am, we've got like escape team, the escape pain. So the escape pain are for those back pain that need conservative management, like exercises, and then rehab we send to the escape team. We've also got escape is for, yes, BFIT is for the back pain, and then escape is for arthritic pain, like hip arthritis, patient that are waiting for like hip replacement, or that want to opt in for conservative management. We send to the escape, but for the BFIT, that's for the spinal, like the conservative back pain. So you can handle it's not only about escalation. Yes, that is the key. It's for you to just see if there is red flag, screen for red flag. That is one of the big one that we do. But we also manage. We also like simple analgesia. Some of us are prescribers, so they can do prescription. We don't have to refer back to the GP to review their medication. Some of us are injection specialists, so we do injection in case of tendinopathies like shoulder tendinitis, and the knee arthritis. Some do injection, so some prescribers, so that's an added thing for the for the FCP. They can always do that within their own clinic without referring for the GPs to do that for them. Does that make sense? So we do a lot.
Well, thank you, Ma. I'm happy that today I'm your student, and very proud of you, sincerely. Thank you so much for what you have done. Wonderful job today. It aligns with our vision. Here in Nigeria now, we are having that vision. We want to advance the profession, and very importantly, it's important to have the first contact practice. I keep telling people, it's not just the fact that we want patients to come to us first. No, what really is the important thing? If a patient has to go through someone when the case is yours, they will pay and they will wait. And when they are referred to you, they will come back to you and pay and also wait. So that's double payment, double waiting. So if a case is a physiotherapy case and they come to you first contact, where the problem is that if you don't know how to identify other underlying diseases and refer, it means you will keep the patient. They may not have symptoms at that point, but the risk, the risk of having it will be there. And if you can't identify yellow flags or red flags, then you are going to keep the patient until they get to a late stage before you refer. So these are important things for us. And I think I'm very happy that we have capable hands that are going to help us to build the profession in that direction. I want to thank you so much. May God bless you abundantly for what you have impacted on us today. And we still are eager to see more as time goes on. After this series, please don't get tired with us. Plan another one for us. But then the next one is going to be a paid one, because if we want it to be consistent, then we need to start to consider people getting out of their way to train us. So, but all in all, thank you, sincerely appreciate you.
Thank you very much, sir, for giving me the opportunity. It's a pleasure, and you've always been my inspiration. Thank you, sir. I'm always available anytime, sir. Inshallah.
Hello, thank you very much, sir. We really appreciate. So I don't know if there's any question. If there's not any question, I think we can close it a day for today.
Okay.
So details for the Google form that we say we'll create will come up after the workshop. So we'll drop all the information in the chat group, that's in the WhatsApp group. So in the absence of any question or comments, I don't know if you have any other things to add.
No, I don't have anything to add. Just a pleasure to be here. Hopefully, we're going to do like a reflect on how we practice, and hopefully there'll be a change in the way we do things, a positive one. And yeah, that's it.
So, inshallah, I know with you by our side, the dream will come into reality by the grace of Almighty. Thank you so much. So, in the absence of question or comment, we'll call it a day. We'll meet next time. Thank you.
Thank you. We did not look into the chat if there is any question. Some people might not be able to, some people might just put any question. So are you going to look into the chat? Do we have any question from the chat?
Yes, there are some questions there.
Okay, so if we can just look into that so they don't feel left out.
So, okay, there is one that says concern the spinal infection. Please, what are the lab tests to look for, ma?
That's a whole lot of thought, like another session, but that's what we are going to be treating next time. So hopefully you will be present and then we're going to look into that. Is that okay?
Okay, thank you, ma. I think that's the only
Right.
question. There is no any other question.
Other question. Okay. Just
That's the only one.
I think the best thing is just to know where we work, what are the pathways. We're not doing the GP's work. The GP are not doing our work. We are not taking the GP's work. The GP are not taking, like, we are kind of even easing the work of the GPs. Because if you look at it with like 10 attendants to the GP, then almost like 7 will be MSK related. So we are there to kind of relieve the work. So we don't even attempt to do the work of the, once we see that this need GP review, we refer to the GP. So I think one of the things that will be a kind of I don't know how to say it, to be honest. Like back home, maybe GP might be thinking, doctors might be thinking, oh, the physios are coming to take our place. They want to do this. They want, no. We're just trying to see how we can optimize the patient, like how we can make the patient much better, improve the patient, without causing any delay, not doing any other person's work. The FCP is a good role, like it's a cool role. I really love it personally. Thank you for having me here. I think we're done for today. See you next time. Am I okay to go?
Yes, ma. Thank you, ma.
Thank you. Thank you.